So hi everyone, my name is Jasmine Gan and I'm an academic clinical fellow in geriatric medicine in Oxford. Thank you very much for this opportunity to present here today. So in the first part of my presentation, I would like to provide an overview of delirium, its pathophysiology and the current management strategies. In the second part of my lecture, I would like to share findings from my research on the prevalence, associates and outcomes of delirium. So I have no financial interest to disclose for this presentation. I thought it would be quite interesting to look back at in history as to where the concept of delirium originated from. So in the 1st century AD, this man here, Celsus, first described delirium. Delirium was derived from a Latin word that means to deviate from a straight line, to be deranged. And despite medical advancement in many fields, the understanding of the pathophysiology and the treatment for delirium remains very limited. So what is delirium and how can we diagnose it? The NICE guideline recommends 2 ways of diagnosing delirium. So the first way is using the confusion assessment method, which is an operationalization of the DSM-4 criteria, or to diagnose delirium by the DSM-5 criteria. So looking on the table on the right, to diagnose delirium based on the confusion assessment method, a person has to fulfill the following criteria. So number 1, demonstrating an acute change in the mental status. Number 2, demonstrating inattention. And either, number 3, a change to the conscious level, or 4, disordered thinking. So inattention can be tested by getting the patient to do a backward counting from 20 to 1, or even just by observing a patient being easily distractible. So in terms of a change in conscious level, in patients with hyperdelirium, they may appear hypervigilant, and in patients with hypodelirium, they will appear sleepy or drowsy. And in terms of disordered thinking, patients may be rambling, or we may notice that during conversation, they may switch from subjects to subject without a logical flow. It is important to also highlight that for many patients, formal tests may not be needed, where observing bedside behaviors such as patient aimlessly picking at their bedclothes or plucking the air are sufficient evidence of a change in mental status. So looking at the DSM-5 criteria, it's an updated version of the DSM-4. So the cardinal features of DSM-5 is a disturbance in attention and awareness, and at least one cognitive feature that developed over a short period of time. Looking at criteria D, it's quite interesting that in DSM-5, it specifically excludes coma from being labeled as delirium. The DSM-5 also provided a broader list of causes of delirium. Delirium matters. So in a recent meta-analysis, delirium is estimated to occur in about 23% of medical inpatients, with a pooled prevalence rate of 15%. So prevalence rate means delirium which occurred on admission. The pooled incidence rate, referring to delirium occurring at some point during admission, is estimated to be about 9%. There are limitations to the estimation of these figures. So for instance, in some studies included in the meta-analysis, patients who are unable to consent or have specific neurological conditions were excluded. So dementia prevalence across the studies varies quite widely as well. Excluding specific groups of patients who are likely to have delirium can affect the robustness of the estimated prevalence rate and incidence rate. So delirium is a huge financial burden to the healthcare system. So one paper from the UK in 2012 quoted an additional cost of £13,000 per patient during admission. Another more recent paper estimated an additional cost of about $800 to $24,000 per patient across various different countries. It is important to highlight that there are also other long-term costs associated with delirium after patients are discharged from hospital. So this cost may be associated with the cost of increased care needs, transfer to long-term care, or cause associated with increased dementia risk from delirium. So here are the risk factors of delirium, which can be broadly classified into the predisposing factors and precipitating factors. Predicting delirium risk in individuals remains very difficult. For instance, cognitive impairment is often undetected or not properly documented, and over half of patients with dementia are thought to remain undiagnosed. Similarly, with precipitating factors such as severe illness, the question remains as to what's the best method to quantify severe illness that will enable us to predict a person's risk of delirium. So developing a robust risk prediction model may help us to identify high-risk individuals and tailor our intervention based on risk assessment. However, this remains a huge research gap. So here I will talk about the mechanisms underpinning delirium. There have been a few theories proposed. So the first is, with aging or in patients with stroke or neurodegeneration, the brain is vulnerable and is not as resilient to exposure of acute stresses. This could be due to disrupted neuronal network affecting the brain's ability to respond to stresses. Here is a graph showing that lower mini mental state examination score, which is indicative of more severe cognitive impairment, is also linked to higher probability of delirium. Secondly, neuronal changes or medications resulting in neurotransmitter imbalance with cholinergic deficiency or high dopamine level can also contribute to delirium. Prior neurodegenerative conditions may have also primed microglia and astrocytes and lead to an exaggerated inflammatory response of the brain. Lastly, brain perfusion abnormalities or blood-brain barrier changes have also been thought to contribute to delirium, whereby a history of stroke and severity of small vessel disease was shown to be a risk factor for delirium over and above baseline cognitive level. So moving on to the management of delirium, the most effective management of delirium is a multi-component intervention focusing on these 10 domains. So multi-component intervention is estimated to reduce incident delirium by 31%. It is important to emphasize that this strategy is for preventing incident delirium and not treating delirium that has presented on admission. There is currently no clear evidence of benefit with pharmacological approach for delirium prevention. In terms of treatment for delirium, the current advocate for treatment of delirium is the multi-domain approach, which is very similar to the prevention strategy. This is based on expert opinion as limited trials had been performed. In contrast, there are quite many trials that were done to assess the use of antipsychotics and acetylcholinesterase inhibitors to treat delirium. But current evidence based on meta-analysis of these trials indicate that these are not effective as a treatment strategy. So moving on to the second part of the talk, I'd like to present my work on the prevalence, associate, and outcomes of delirium. So we will first look at the current research gap and limitations. So many existing studies are selective in their cohort. So for example, as mentioned earlier, in some studies, patients who are unable to consent, either due to a lack of capacity or lack of a proxy, patients with known dementia or other neurological conditions, or patients who are very ill may be excluded. These groups that have been excluded are likely to have higher rate of delirium and have poorer outcomes. Secondly, there is also inconsistent adjustment for confounders, with significant adjustment not accounted for. So most studies do not adjust for all three of acute illness, comorbidity burden, and frailty, and most only adjust for either acute illness or comorbidity burden. Lastly, majority of studies also had a sample size of under 500. The studies were conducted in different settings, such as in specialty wards or settings with varying dementia prevalence. This contributes to the heterogeneity when the meta-analysis is done to get a pooled estimation rate and may affect the reliability of the average estimates. So the aim of our research is Firstly, to obtain reliable age-specific rates of prevalent and incident delirium in an unselected inclusive cohort. And number 2, to assess whether delirium is an independent predictor of length of stay, increased care needs, and mortality over and above comorbidity burden, illness severity, and frailty. In our study, it is conducted over 6 cycles of 2-month period during 2010 to 2020. It is a prospective cohort observational study that recruited consecutive admissions to acute medicine. So my role in the research was I was responsible for collecting data for the cycle number 6. I then assembled the data for cohort 1 up to cohort 6 and undertook data checking and cleaning, including identifying missing data and reconciling it from medical notes, and then subsequently performing the data analysis. So in terms of defining the variables, in our study, delirium diagnosis was made prospectively by geriatric consultants using the confusion assessment method. So in our hospital in Oxford, we run a firm-based acute medical take with continuity in care from the consultant to ensure robustness of the diagnosis. So prevalent delirium is defined as any delirium which occur within 48 hours of admission, and incident delirium is any delirium that were diagnosed 48 hours after admission. If delirium was present on admission, a 48-hour period without evidence of delirium was required before a new episode of delirium/incident delirium is recorded. Severe illness is defined by SIR score of more than 1. So we use an updated weighting of the Charlson Comorbidity Index that was developed by the Dr. Foster Intelligence Unit at Imperial College, and which is used by the NHS to assess death within hospital. Our frailty markers included the following. So dementia is determined by a mix of history from patient or relative, or from GP or hospital records. All other markers are routinely collected data during admission. Increased care needs refers to the increased care package or a patient who is discharged to a new setting, such as to a rehab unit, to a community hospital for further rehab, or to the long-term care, such as care home or nursing home. So these are the statistical tests that were undertaken for our analysis. So for baseline characteristic, we applied the t-test or Mann-Whitney U-test or the chi-square test. Logistic regression was also performed to assess the univariate and multivariate associations of delirium. The risk factors associated with delirium were analyzed for patients aged 65 years and above. So we also performed a Cox regression to assess the mortality outcome beyond the admission period. So in terms of baseline demographics, our overall cohort, there were 1,739 patients, and in the subset cohort of patients aged 65 years and above, there were 1,169 patients. Patients with delirium are significantly older than patients without delirium, as observed here. So there is an equal distribution of gender between male and female patients. So moving on to the results, in our overall cohort, 23.9% of patients were diagnosed with delirium. Prevalent delirium was much more common than incident delirium. With the current management of delirium mainly focused on the prevention of incident delirium, this does not fulfill the needs of the majority of patients who present with prevalent delirium. Interestingly, around half of patients who had incident delirium also had prevalent delirium, which is delirium present on admission. So looking on the right here is a graph of the age-specific delirium rate. So as we can see, the delirium rate increased steadily across each age groups after age of 65 years and above. So in terms of the factors associated with delirium, patients who are above 75 years old has a 2.3 times increase in odds of developing delirium. The likelihood of delirium increases by 4% for every 1 point increase in the updated weighting of Charlson Comorbidity Index. A SIR score of more than 1 is also associated with a 1.53 odd ratio, which is equivalent to a 53% increase in odds of developing delirium. Here I present the association between frailty markers and delirium adjusted to age and sex. So the adjustment reduced the strength of association, but not to a large degree. So all the predefined frailty markers were found to be significantly associated with delirium, with the strongest association noted between urinary and fecal incontinence, high pressure psoas, and also dementia. So in terms of outcomes, the odds for length of stay of more than 7 days, death during admission, and increased care needs were higher in patients with delirium. After adjusting for the confounders age, sex, comorbidities, illness severity, and frailty markers, this association remains significant, highlighting that delirium remains an important predictor of these outcomes over and above the confounding factors. We also assess the rate of new discharge to care home or nursing home directly from hospital. This was not significant after adjustment for confounders, probably due to a small number of patients who were discharged directly to care home or nursing home, as most of our patients probably had increased package of care or was sent for rehabilitation before further assessment to see if they need to be admitted to long-term care. So this is the risk of death across different follow-up period. So the risk of death is highest. It differs significantly between patients with and without delirium, and the risk of death is highest and most concerning within the 30 days of admission, whereby the risk of death increased in the delirium group by 79%. So our study has several strengths and limitations. Whilst the study is composed of an inclusive cohort, it is derived from a single-site tertiary center, which may limit its generalizability to healthcare settings with different demographics of population and different healthcare service provision. So secondly, delirium diagnosis were diagnosed by experienced geriatricians. However, we did not assess for inter-observer reproducibility. One main strength of our paper is that we adjusted for significant confounders when determining the associations and the outcomes of delirium. However, due to resource constraint, we did not collect data on the factors associated with delirium in patients under 65-year-old. However, the number of delirium in the patients of age group of less than 65 were very small. So in conclusion, the rate of prevalent delirium is higher than incident delirium. Current management of delirium is mainly focused on the prevention of incident delirium. However, this may not have substantial impact on majority of patients who present with prevalent delirium. Delirium is an independent predictor of poor outcome, which places significant burden to our health and social care system. Delirium predicts increased care needs upon discharge, and this should prompt early discharge planning to ensure timely discharge from the hospital. Lastly, the increased risk of death associated with delirium emphasizes the importance for healthcare professionals to consider initiating advanced care planning discussion, especially in patients who are at high risk of delirium. I think there is an urgent need for funding into delirium research to further our understanding of its pathophysiology and to develop more effective treatment and strategies for delirium. It is also important to consider shifting our focus on developing effective strategies on preventing and managing delirium in long-term care settings. So that's the end of my presentation. Thank you very much for your time to listen.
Well, thank you, Jasmine, for that very interesting presentation on the data you've collected on delirium in acute medicine cohorts. So for everybody watching, I'm Sarah Pendlebury. I'm Professor of Medicine and Old Age Neuroscience here in Oxford, and I've had the pleasure of supervising Jasmine over the last year, where she's been working with me on her academic clinical fellowship. And I just, as part of this, we're going to have a Q&A session. So I'm going to ask Jasmine some questions really to try and sort of dig a bit deeper into the work she's done. So the first thing I thought was interesting, Jasmine, was about the time course of the risk of death after delirium. So we saw in your talk that the risk of death seems to be quite front-loaded and gets less with time after the delirium episode. And I just wondered if you could expand a bit more on that and perhaps give us a bit more information about it.
Yeah, so I think our study demonstrated that patients with delirium has a significantly increased mortality over the follow-up period of 3 years, which is independent of the confounders that we adjusted for, including comorbidity, frailty, and illness severity. And like you mentioned, what was really interesting is that the risk of death associated with delirium declines substantially with time, and the risk of death is highest during the earlier periods of follow-up. So I think an interesting question would be why some patients with delirium are more susceptible to early death and others may survive longer. To answer this question, we would need to undertake a stratified analysis based on subgroups that may help us identify predictors of early death versus late death in people with delirium. So this could be related to the etiology or the cause of delirium or the severity of illness that the patient is experiencing. Age may also be a possible explanation, whereby the older the patient is, they naturally would have a shorter survival time compared to someone younger. Frailty may also play a role, whereby delirium may have a worse impact on people with underlying cognitive or physical frailty compared to those who are fitter. So there was a study back in 2012 which showed that patients with delirium and frailty are thought to have a shorter median survival compared to patients with delirium who are fit. So I think what's important to learn from this finding is that it's not only important for us to recognize delirium, but also to be able to identify patients with delirium who are at risk of earlier death. This can help us to guide our understanding of a patient's prognosis and facilitate discussion with the patients and their family regarding advanced care planning in the most vulnerable patients.
Yeah, no, I think that's right. And I think the other thing to maybe sort of highlight is that if we're thinking about using delirium as a flag of those at risk of future dementia, obviously, if we were wanting to recruit patients for trials, we would want to be recruiting the patients that we know are going to survive for a reasonable length of time to allow us to do an intervention. So I think that's further work that needs to be done and could lead to some very interesting developments. Okay, and so what do your findings tell me how we might do better at predicting risk from the factors that you've identified so far, and what are the challenges about applying those sort of risk models in practice, do you think?
Yeah, so I think the cause of delirium is usually multifactorial. And like we mentioned in the talk, it's likely to be an interaction between various predisposing and precipitating factors. With our finding from like a very well-characterized cohort would allow us to determine the strength of association between each risk factors and delirium more accurately. So this would help with the allocation of weight for each factors when we do develop a delirium risk prediction model. I believe there are quite a few delirium risk prediction models that has been studied, but there remains quite significant challenges with the practicality and feasibility of implementing delirium risk score. So one of the advantage in our study is that the risk factors that were studied were extracted from routinely collected data. And with the advent of electronic patient record, we can select routinely recorded data, which can then be automatically extracted and be applied into an algorithm that can determine a person's delirium risk in real time. One of the main challenge with creating a delirium risk score as well is that the variables or the risk factors should be defined in a practical sense that it would be feasible to use in a busy clinical setting. So for instance, we demonstrated that patients with a SIR score of more than 1 is associated with roughly a 53% increase in odds of developing delirium. This is quite a practical way of defining illness severity, as the SIR score could be derived using data routinely collected during patients' assessment and can be easily integrated in a delirium risk prediction model. Another example is with cognitive impairment, which can be defined as patients who are known to have a diagnosis of dementia or patient with a cognitive score below the cutoff of a cognitive test. So in our hospital, patients are tested using the AMTS routinely, as it is easy and more feasible to perform in an acute medical setting. So so I hope the data generated from our study can be used to develop a risk prediction model that is simple to use and will be able to predict delirium risk reliably.
Yes. Okay. Well, I agree with you. That's the key challenge, is around making it feasible and implementable in practice, isn't it? Without putting additional burden on staff and patients, which is the key consideration, really. We've just got about 4 minutes left now, Jasmine. So obviously, as part of your work, you assembled a lot of data that was from 6 cohorts collected over a nearly 10-year period. Perhaps you could tell us some of the sort of challenges you encountered in that process.
Yeah, so I found this process of assembling the data a very good learning opportunity and gave me an insight into the challenges of managing data set with large sample size. And as you mentioned, this data was collected over 6 different cycles across 10 years by different group of clinicians. This does result in some degree of inconsistency as to how the data were recorded in each variable and fields. So I had to standardize the data and code it in a format that we can eventually analyze it on the statistical package. I think moving forward, it will be important to ensure people who are involved in the data collection uses a standardized format. So this could maximize efficiency when it comes to the data analysis. There were also some missing data that were noted on some variables or patients. So I went back to review the notes again to identify if the missing data were truly missing or that the data was available but was somehow missed off and not entered. For our study, we were also very fortunate to be able to access our data from multiple sources, including patients and relatives' history, hospital records, local GP records, and information from the coding team. So compiling data from different sources, it was quite time-consuming and labor-intensive. But what we did achieve was a very well-characterized cohort that can answer questions with details that big data study set may not have access to. So for example, we could classify the delirium based on whether the patient had prevalent delirium or incident delirium and the rates of prevalent and incident delirium. I think what this means is that our study could potentially act as a reference standard for other study, whereby if there is significant discrepancy noted in the rates of delirium from other studies, we could then explore further to find out the explanation as to why that discrepancy was noted.
Yeah, no, I think that's a really good point, Jasmine. And I think with the move towards big data studies and the use of these data sets of many sort of tens, if not hundreds of thousands of patients, is very important to keep a mind on the accuracy of those data. And you mentioned sort of the coding issue, and we did some studies previously that showed that the coding of delirium had previously been very poor. With some efforts that we've made system-wide, that has improved enormously over the last sort of 6, 7, 8 years, but it's nevertheless not as accurate as we would have in this very clinically in-depth study. So I think we need both for research into things like delirium. We need both the phenotype studies that are small and the very large big data studies, and we need to use both together to get better overall findings for our patients. Yeah, I think that's our 10 minutes up for the clinical questions, Jasmine. So I had a couple of non-clinical questions for you in relation to the Turner-Warwick scheme. So the first one is why did you apply for the Turner-Warwick scheme?
Well, firstly, I have to thank you, Professor Penderbury, for introducing the lecture scheme to me. I think the main reason I applied for the scheme is that it is such a great platform to share our research findings. And I hope this would also highlight to everyone that there is still a lot of work to be done to advance our understanding of delirium and how to best manage this condition. And I also saw this scheme as quite a unique opportunity to develop my skills and my confidence in delivering a lecture to a wider audience.
Yes, and I think the other nice thing for you is that there are many academic trainees who choose acute internal medicine or gerontology, geriatric medicine for their subject. So I think it's been a really good way to highlight what you can do and the sort of studies you can participate in as a sort of geriatric medicine, acute medicine trainee, which I think is really needed in this very sort of large but understudied population, really. And the second question was what you felt has been the highlight for you about the Turner-Warwick scheme and what you've got out of it.
I think having the recognition of the work that we undertook really makes the whole effort felt really worthwhile. It also allowed me to reflect on the achievement of the project that I undertook over the last year and basically confirm my interest in research, which I hope to advance in future. It is also a very good motivating factor for me to learn more and also be involved in conducting good quality research. And I hope to be involved in other exciting projects that aims to improve the healthcare of our older population in future as well.
Yeah, no, I think that's a great answer, and I think your work on these cohorts has been really very, very helpful and important in giving us precisely that reference standard that we can use then when we're looking at our big data sets in older patients. Not just the accuracy of coding for delirium, but also the accuracy of coding for other frailty syndromes, for example. And as you know, there's a lot of increasing interest in frailty, but we're not really yet entirely sure how best to capture that in real time in our patient cohorts in the acute setting in a way that's going to actually inform care in real time. Yes, I'd like to thank you once again, Jasmine, for all your hard work with us over the course of your ACF year, and I'm delighted that you've had this opportunity to present the Turner-Warwick lecture scheme. So thank you very much.